Hello, my name is Charlotte Gonzalez, and I have been sick since August 5th, 1990. Most years since my onset have been spent bedridden or housebound, yet I and the patients you see here are the tip of an iceberg. I have friends who are too ill to watch or listen to this videocast, friends who can't take care of themselves, friends who are in nursing homes, friends who are barely able to pay for food and shelter, friends who live in the desert due to chemical sensitivities or exposure to toxic mold, and friends who have committed suicide. If they had been properly diagnosed and treated as having a neuroimmune disease using the Canadian consensus criteria, perhaps their lives would be different. Perhaps my formerly hardworking friends would not be disabled and in need of income assistance. A recent study indicated up to 68% of us are in this state. The cost to the economy, $18 to $23 billion annually. Tomorrow you will hear from representatives from the Social Security Administration and the Department of Labor. Both agencies can help. SSA could give this disease the status of a listed impairment in its Blue Book, which would shorten the process to secure Social Security disability insurance. DOL has advisors who help those with ERISA plans obtain improperly denied health and retirement benefits. There is no reason these advisors could not be trained to help with disability plans. DOL also could support plaintiffs whose disability benefits have been denied by filing amicus briefs in court. But these are Band-Aids. Income assistance is a necessity only because this neuroimmune disease has been put on the back burner since the CDC investigated an outbreak of epidemic neuromyasthenia, also known as myalgic encephalomyelitis, or ME, around Lake Tahoe, Nevada in the mid-1980s. Chronic fatigue syndrome, the name and accompanying definition created by the CDC in 1988, bears no resemblance to the disease those in the outbreak had. The CDC insists CFS is an enigma, yet there is nothing mysterious about ME. Outbreaks have been documented since 1934. In 1956, Dr. Melvin Ramsey coined the name, and in 1969, the World Health Organization classified it under neurological disorders. Ramsey's description of ME in 1986 was built on and expanded by, again, the 2003 consensus criteria. Use this as a blueprint for a new international research definition. This is sorely needed for selection of proper patient cohorts. And please keep in mind that the CDC does not have exclusive authority to define or name diseases. The American College of Rheumatology, for example, defined fibromyalgia. Stop ignoring the evidence of immune dysregulation, neurological dysfunction, and the presence of infectious agents accumulated by researchers over many years. Look at the studies by Dr. Elizabeth Dowsett that found enteroviral infection in ME in 1975. And while you're at it, look at the ME research before 1988. Listen to people like Dr. Martin Lerner, who successfully treats ME patients with antivirals. And stop ignoring the most promising research to date, that of a retroviral connection to this disease. This is groundbreaking research. It is unreasonable to ask us to wait 3 to 4 years for the results of the Dr. Ian Lipkin's XMRV study. Research into this potential infection's etiology should be given the highest priority, but it's not. Applications for research into HGRVs are denied NIH funding, discouraging potential investigators. Why is NIH sending this message that researchers must wait to follow this clue? Compare the reaction of the US government to AIDS to our disease. Both occurred around the same time. Yet only 3 years after the first US AIDS case was detected, HIV was identified as the causal agent in 1984, and the test was licensed the following year. Treatment in the form of the drug AZT was approved in 1987. We deserve the same response. There are approximately 1 million of us. 25% are assumed to be severely ill. Some are unable to move, must be tube-fed. Some die of cancers and suicide. There's no quality of life when one is unable to care for oneself. Dr. Mark Lovelace told Congress in 1980 that his AIDS patients in their last week of life were less disabled than his CFS patients. AIDS is now a manageable chronic disease, yet it still receives huge governmental support. What we need, what we demand, is the same type of response from NIH that AIDS gets. In 1988, the NIH Office of AIDS Research was established directly within the Office of NIH Director to its multisystemic nature. AIDS is coordinated across various institutes and centers. Neuroimmune disease easily affecting 10 million, and including ME, CFS, fibromyalgia, Gulf War illness, chronic Lyme disease, and autism, is also multisystemic. An Office of NID Research following the AIDS model could coordinate research, determine IC budgets, and ensure all funding goes to the highest priority research. Public policy toward this disease must change radically. I have with me a petition signed by over 550 people stating that collectively we do not recognize the CFIS Association as a representative agency. Listen to new voices like ANITA, Advocates for Neuroimmune Disease Awareness, and the International ME Association. Check out XMRV Global Action, CFS Untied, and MECFS Forums Wiki. Stop talking and start acting. There is much work to do. Do it. Do it now.
Thank you, Charlotte.